let's talk about these skeletal muscle diseases. There's not that much. There's not that much. I may run over. If you guys have to leave, that's fine. But I'll just make a little like 10 after or something like that. But it'll make sense to you guys. Okay? Skeletal muscle diseases. First off, strain versus sprain. You hear these all the time. Okay? A sprain is when you overstretch a ligament. And if you remember what a ligament is, it's connecting bone to bone. Okay? A strain is overstretching a tendon or a muscle. And a tendon, remember, ligament, bone to bone, a tendon, muscle to bone. Okay? Basically, it's the difference between a strain and a sprain, and that's how I put a T there for tendon, so you understand that strain is for tendon. But the treatment for both of these is basically the same. Do you guys know anything about rice? Right? Yeah, there you go. That's where it comes in. Rest, ice, compression with an ACE bandage, and elevation. Okay? So that's where that comes in. All right. So let's just talk about muscular dystrophy. Right? You've heard of this. What is muscular dystrophy? Well, back in the day, this is when Jerry Lewis, he just died last summer, but he's the one that started the whole Labor Day telethon on muscular dystrophy. Now, they still do it, but he's obviously not doing it anymore. But it's Jerry's kids is where that was. Well, it's a genetic disease, okay? It's X-linked. So let me ask you this, X-linked. Does that mean more males have it, more females, or it's equal 50-50? Males, good, okay? It's X-linked. So males have more than females. It's a mutation with the gene that makes something called dystrophin. Oh, what is dystrophin? Okay, well, I got a picture to help you, okay? But a dystrophin is needed to prevent muscles from becoming weak. This is what it is. This is inside the cell, the muscle cell, okay? Here, this yellow area is the sarcolemma. That's the cell membrane of the muscle, okay? Here is those wonderful A bands, the sarcomeres, the contraction organelles. So you have actin and myosin. Now, just think what's happening here. Inside, when it contracts, it's not going to contract that. So it's not going to help you. Having just something, if you have a balloon with water in it, and something inside is contracting, the outside of the balloon is not going to change any shape unless that thing that's inside contracting is attached to the balloon itself. Because then when it contracts, it's going to pull the balloon in too. Does that make sense? So we have something there. There's something here called dystrophin. Dystrophin connects the sarcomere that's going to contract with those wonderful calcium and all that stuff, and it is actually attached to the cell membrane. So when this contracts, it's also going to bring the cell to contract also because it's connected. Is that clear? Can you visualize that? Yeah? So what muscular dystrophy is, and there's a few different types, is either they don't have this dystrophin, so it still contracts, but the muscle's not going to contract. Or this is somewhat malformed. It contracts somewhat. Okay? But that's what dystrophin is. Is that clear? Okay? So there's many types of muscular dystrophy. The most common type is something called Duchenne's muscular dystrophy, DMD. Okay? This is when the dystrophin is absolutely absent. It's not there. This is the more severe one. It's the most common one. They usually die in their 20s. Okay? We also have another one called Becker's muscular dystrophy. This is just a defective, I don't want to say just, but it's not an absent dystrophin. It's malformed. So these, it's not as severe as Duchenne's. They usually die in their 50s or 60s. Okay? There's something called Gower's sign. Gower's sign, I'll show you the next picture. But they usually die because the respiratory muscle, the diaphragm, those are not working. They start getting affected. That's what they usually die of. Or if the heart gets affected itself. So let me talk about what Gower's sign is. Gower's sign is if a child's on the ground, right? Let's say let's say a 5-year-old is playing on the ground. The way he gets up, it's a him, well, more likely it's a him, right? So if he gets up, he has a very unique way of getting up. What happens is his thigh muscles are not strong enough. Muscular dystrophy usually hits the thigh muscles before anything else. So they're the ones that get the weakest. Now, if I want to go from here to here, I'm using my thigh muscles, squats, right? So that's what I'm using over here. If they're weak, I'm going to be using other muscles to get up off the ground. So he usually will use his hands to try and walk his way up and use his arm muscles to get up, and he'll use his calf muscles to get up the rest of his body. Notice that his thigh muscles are really thin. But because he uses his calf muscles more to compensate, they're huge. You see that? So this is, you ask, if you talk to a parent and you notice that the child's getting up this way, you say to the parent, is that how he usually gets up? Oh yeah, he's been doing that for a year, that's just his own thing. And that might not be his own thing. He might have early signs of muscular dystrophy. You want to see what his legs look like. Are they atrophied in the thighs? You're going in the medical field. These are little signs that you should be able to pick up and catching these things early so that they can get the proper treatment early. Okay? You see how we're doing this? Okay? So that's what that is. Okay, the rest of this is what I'm going to do over here. It's this whole thing. You guys understand this? Now let's talk about diseases. Who here has heard of Myasthenia Gravis? Look, it's over here. Look what's going to happen here. Myasthenia gravis is an autoimmune disease. What's happening is that you are producing antibodies that are going to block the acetylcholine receptors. They make these antibodies, and they are going to bind to these receptors. So this is what myasthenia gravis is. Okay, it's easy to understand. If you understand autoimmune diseases, we're building on that. They make antibodies to attack the receptors, not acetylcholine. They attack the acetylcholine receptors. So they bind to it, and this is what happens. They take them, they internalize it. They take this whole thing, bring it inside, and it gets destroyed. So you're not going to, it destroys the receptors for acetylcholine. So the problem is not acetylcholine getting in there. You make enough of that. There's nothing wrong with this. It's because there's receptors, you're losing them all. So my question to you is this. If you understand that and how it normally works, if we lose the receptors and acetylcholine has no place to bind, do these people get flaccid paralysis or spastic? Hey, beautiful. Right? Does it make sense? Because you can't get an action potential to get on this side because this button can't be pushed. This is exactly what this is. Now, if you understand that, you'll also understand the goal to treat it too. So it's antibodies that block and destroy, brings them in, internalizes it, and destroys those receptors. Okay? Now, usually what they do, the symptoms usually affect the face and neck usually first. They have, if you ask them to look up, after about 10 seconds, their eyelid starts drooping because it starts tiring out at a much faster rate. They have problems swallowing, moving their tongue. Okay, it's usually this area first. So when I have some problems swallowing, they're thinking this. Now, this is still a rare thing, so you don't just hop on the bus and just say, hey, he's got myasthenia gravis. No, I mean, you have to look at other things too. So they usually die, if untreated, they usually will die from the respiratory muscle. The diaphragm is not working, okay? So this is your axon. Here's your axon terminal, all right? Just kind of this way now, the picture. These pink dots are going to be your acetylcholine. These red ovals, eggs over here, those are the receptors for acetylcholine. This is the muscle. This is how it normally works. In a person who has myasthenia gravis, they have these autoantibodies, these yellow wives, that bind to the receptors, internalize the whole thing, and destroy those receptors. Now you have less receptors. There's no issue with the acetylcholine, you have issues with the receptors. And I see that you do understand the symptoms of this because you all said it's flaccid. Okay? So it internalizes it and destroys them. Okay? And this is showing the same thing. So, and here's, this is called ptosis. You have them look up, and then all of a sudden it stays there for like 20 seconds, and one eye starts drooping. We call it ptosis. Right, the P is silent. Now, don't get me wrong. There's other reasons for ptosis. All right, but you're putting everything together. Problems swallowing, problems moving his tongue, there's ptosis. You start putting things together over here. Okay, so he looks. That's what this is. He's looking up, and this eye is starting to droop. Okay. So the treatment for this, the goal is this. You can't do much about the receptors when they get destroyed. But is there a way we can get rid of those autoantibodies? So here's the theory that just seems to work pretty well. If we could increase the amount of acetylcholine in this cleft, hopefully, the goal is this. If this gets saturated with acetylcholine, that these acetylcholine are strong enough to knock these antibodies off the receptor. That's the goal. Does that make sense? So what do you do? How do you get more acetylcholine there? What do you do? What should you do to try and get more acetylcholine in that area? You have something that's breaking down acetylcholine. What is that enzyme? Acetylcholinesterase. So if we could actually stop that acetylcholinesterase from breaking down acetylcholine, you're going to have a lot more acetylcholine there. And that's what it is. You actually are going to give these, and it's a list of drugs, but a cholinesterase inhibitors to try and increase the amount of acetylcholine by decreasing the destruction of the acetylcholine. Does that make sense? Right? All right? And that allows more of the acetylcholine to flood that area and hopefully be able to knock off those antibodies, those autoantibodies. And it works pretty well. Okay? There is some, you could also do this too. We don't understand the mechanism, but if you remove the thymus, not the thyroid, the thymus, that there's a connection with the thymus and myasthenia gravis. So they also could have some kind of help with that too. Okay. The questions about myasthenia gravis? Do you understand? Knowing the normal, you just we'll do some more of them. Neuromuscular toxins, pesticides, killing off the pests off the tree so you can actually eat the fruit and stuff, right? You breathe in that stuff, it's bad. Why is it bad? Well, what happens is it's going to block these. Now, we're not talking about myasthenia gravis anymore, right? So what pesticides do is that it's going to inhibit that enzyme. So if you inhibit that enzyme, does your acetylcholine increase or decrease? Increases. If it increases, is there going to be more acetylcholine on the receptors? Yes. Does that mean it's going to keep that button pressed all the time? Yes. Does that mean that this muscle is going to always be contracted? Yes. Does that mean is it spastic or flaccid paralysis? There you go. See, it's not earth-shattering, but you do need to know the normal. Okay? So that's how pesticides work. Okay? And it can be so much that you're going to suffocate. The muscles in the neck, you can't breathe. Okay? You also have this thing called Curare. I know some of you are actually thinking about going to be a nurse anesthetist. So we actually could use this. But Curare is a plant poison. And if you ever watch the movies from, let's say, Native, South America and stuff, they do those little darts. And you go, oh, what the heck? And you fall down, right? That's what this is. Okay? But how this works is that it blocks, I'm getting messy, but it's actually, the Curare is going to block these receptors. So when it blocks these receptors, the acetylcholine is still coming out normally, but it has no receptor to bind to because there's a blockage that's going on there. Does that make sense? So in a person who's got Curare, is he going to have spastic paralysis or flaccid? Flaccid, right? It makes sense. Is that clear? All right. What about one or two more? Black widow spider. The black widow spider, right? One of the venomous things we got on, at least in North America. There's two major spiders we got to worry about in North America that are deadly. This is one. What's the other one? Brown recluse. Okay? And I'll talk about that briefly, just as a FYI. But this one, what this does is it's going to stimulate more acetylcholine coming out for this. More acetylcholine is going to come out of here. So if that happens, this is being flooded with acetylcholine. They're going to bind to these, which means you're going to have, and there's going to really bind to them, there's going to be many of them on there. Are you going to have a spastic paralysis, or are you going to have a flaccid? Spastic. Is that because you just read that? No, it's because you understand it, right? It makes sense. If you understand the normal, think of all the different things that can go wrong. There's going to be bound to be something to cause that, right? So that's what happens over here, okay? That's what a black widow spider bite looks like, right? And then the other one, this is just an FYI, is the brown recluse. Yeah, this is, but it has a very, the black widow spider, be careful with this, obviously, but a lot of people say they see the spider and they stomp on it, right, after you get bit. You know, it's a common spontaneous thing you're going to do. But you want to see the underneath because it has that unique, the red hourglass. But when you step on it, you don't see it anymore. So you just bring it and they'll, bring it to the hospital and they'll see if they can look at it. The brown recluse, it causes more necrosis and dead tissue. That's what we're concerned with. And a lot of GI symptoms. So I'm not going to ask you about it over here. But I'm just putting it because we talked about the black widow. But they have this classic violin pattern. You see the violin pattern on there? Look at that, huh?
Sydney, don't move your head.
But you see the violin pattern? Again, when someone sees it, they stomp on it, but you don't see the violin pattern because now it's all mushed. Okay? So that's what that is. And that's where, you get a bite.
Oh
it gets pretty
God.
necrotic. Yeah, it gets pretty good. So that's after, a little bit after
Look at the
one.
one at 30.
All right? So that's black widow. Again, I won't ask, not black widow, but I won't ask you about the brown recluse. But let's talk about some infections really quickly. Okay? Polio. All right? We'll get more into about polio when we talk about the nervous system. Okay? It's a virus that attacks the motor neurons upstream. So in other words, this is downstream. This is where your axon terminal is. What polio does is much higher, and it's going to happen in the spine. Okay? And that's what causes paralysis, but we'll talk about that later. You also have tetanus. It's from Clostridium tetani. Okay? And this thrives on low oxygen areas like punctured wounds. We talked about that briefly. But we'll talk about that a little bit more a little bit later. But the other one, and that's tetanus. It's a pretty graphic one. It's not really how it looks. I got that from Wikipedia. That's a pretty graphic one, but I have a better picture of a dog having tetanus and what it actually is. So botulism. Botulism, and this is caused also by Clostridium botulinum, and this actually is acquired bacteria through canned and bottled foods. Honey. Who here has heard this? Don't ever give a baby honey. Yeah, somebody said. The reason why is because of the botulism that could be in there. We can eat honey, but we have a stronger immune system than a baby. Does that make sense? So we're able to withstand that, but a baby can't. So that's why they say don't give babies honey. Now what this does is it will actually, botulism blocks the release of this acetylcholine. If it blocks it, then is anything going to bind here? No. If nothing binds on here, are you going to have a contraction? So will they have flaccid paralysis or spastic? Come on, this stuff's too easy for you guys. You see it? It's a little bit fun. And this is also telling you a little bit of Botox. Okay? So this is just an overview of the things we just thought: polio, tetanus, botulism, myasthenia gravis.